Welcome everyone to the May 2025 Q&A, and you've got myself, Sherry Teague, and Cindy Kraft. We are the owners of K&K Healthcare Solutions, and the reason that we do this wonderful job is so that we can help you and your agency navigate the difficulties that are present in home health currently. So, Cindy, are you about ready? I think we have an audio issue with Cindy. Let's see what we can do with that.
How about now, Sherry?
I got you now. Okay, so we've had an interesting day trying to get and navigate Zoom, and so I apologize for the zillion CCs you're getting at the bottom of the screen. But how are you doing today, Cindy?
I'm doing good. I think that, I just want to acknowledge and appreciate folks patiently in the live session trying to figure out where we were at the beginning and what happened now. Technology, when it works great, is wonderful. When it's glitchy, it's frustrating. But knowing that our target audience is home health, we're used to most days being glitchy. So we want to make sure the time we have together, we maximize and get to some really good questions that got submitted since our last session.
Yes, and our first question is a long one, Cindy, so I'm going to try and summarize it the best that I can, and I'm putting it up for everyone else to see the full question. And I believe, honestly, that this one might be 2 or 3 questions. So I wanted to touch base first about how CMS has changed the way that they're allowing agencies to pick the discharges and the discharge levels of activity for folks in the GG. So if CMS inputs 88 or 09s at start of care basically to match the DC function level for each task, it's what this agency's been seeing. Per the OASIS guidelines, the patient couldn't perform the task. So what do you think CMS's plan is for those items that they can't perform?
Okay, so I've been looking at this question ahead of today, and folks can take a moment and read through it in the chat box. It's quite lengthy. I think I can condense it down to this is not the only person frustrated with the change made with respect to HHVBP in terms of the ability to control or the lack thereof of what that discharge score is going to be. I think it's interesting that back in the day when we had the original version of the GG, we had the column, as we well remember, of what their current ability is, and then we had the goal column. From my personal experience and the number of charts I looked at during that period of time, I saw agencies that seemed to be quite diligent about reasonably projecting a goal, and others that I'm not sure were paying all that much attention when nearly every single patient was going to end up an O6 independent in every single thing listed. I think that some of that contributed to CMS making a decision that, as opposed to us being the ones throwing out a target, that they were going to run analytics on that chart and use it as a predictive model with respect to what they think they'll be capable of at discharge. The sticking point in that, I think, one is feeling a loss of control. So if I'm the clinician and I'm actually seeing the patient, I should be the one to project the goal. Well, we can say that now, but it's already been taken out of our hands. The bulk of that question, I think, is really concerned about the whole what happens with the non-attempted codes. We've talked about this on more than one of our previous Q&As, but it's important to revisit it because now that we're in a situation where the financial implications are very real for this move in VBP, is those non-attempted codes do not have a one-to-one match in terms of how to do the math appropriately to make a prediction. And so being part of that technical expert panel, there were different discussions about what are they supposed to do? So you can't really do math. If you're saying I'm moving from a 4 to a 6, well, you can see that's a 2-point difference. But if I'm starting out as an 8-8 and end up a 4, what is that? A 84-point difference? I mean, that isn't going to work smoothly with respect to calculating change. So there was discussion about, at one point, what if you took all of the non-attempted codes, the 4 versions of them, and made them all dependent? Like just change them all in the math to O1. Well, there was some rather heated discussion about that with respect to things like environmental limitations, patient refusals, really are not a direct correlation to them being dependent as defined in that response. It could potentially sort of kind of shoehorn its way in with 8/8s, definitely not with 9s, because you're saying you couldn't do it before, you can't do it now. How is that ever going to work out as a 1? So they stepped away from that and went to more of a statistical look at that assessment as a whole, project an answer. Yes, it was quite vocal that if you're going to essentially guesstimate an answer, why can't you let the clinician do it? Again, we make our points, we participate in comment periods. That doesn't always change what they're doing at that particular time. I appreciate the concern about the not attempted. The fact that it's leading to not attempted code phobia. I'm never going to use them. We should never use them. They're always going to be a problem. I want us to take a step back for a minute. I'm not saying we should only focus on the GG items that are directly in VBP. But for purposes in the anxiety around VBP, we have to remind ourselves the items used are not all of the parts of GG. As a matter of fact, a lot of key parts are excluded. Upper body dressing, lower body dressing, footwear, ambulation to distances of 150 feet. None of those are part of that calculation. So I'm beginning to wonder if this is so unfair. I am so unhappy about the ANA code being converted to something else through magic math. Do we step back and say, okay, how often should I as a clinician be using a non-attempted codes on things like eating, rolling, sitting up, laying down, standing up? I mean, I can see where we get into issues of their abilities being significantly problematic in those higher level ADLs, in that longer distance mobility. But how many of our home health patients really cannot walk 10 feet? I mean, it might take 2 people to do it, but legitimately are unable to get to 10 feet. I think there's a very small population of patient where non-attempted codes would have been on any of these to begin with. And I think some of that anxiety requires us to step back, take a breath, and say, honestly, regardless of the question, an ANA code should be the last resort, that I followed all the instructions to the best of my ability. But contextually, HHVBP is focused on 10 feet and 50 feet with 2 turns. It's not focused on 150 feet. So if I end up with a patient who can successfully complete the first 2, even with the help of 2, and I score them as dependent, but they cannot legit get to 150 feet. They're done at 75. There's no way they're getting there. And I'm going to accurately, per the guidance, put a not attempted code, an 8/8 or a 9, depending on circumstance. I don't need to lose sleep over that and worry that they're impugning that into something else. That's not part of the discussion. So I think I'm not trying to devalue the anxiety. I think some of this ANA hypervigilance and worry about what they're doing, I think we're thinking about the entire GG data set, and that's not what it's occurring with. It is that subset. And when you look at that subset, there have been many complaints that say that's too easy. Those are the way more simple tasks: to roll, to sit up, to eat. Those are things a patient generally should be able to do before you ever let them go home, or else they probably should be in a facility at a higher level of care. So I want us to really be committed that ANAs are not phobic, that we never ever touch them, that we make some degree of peace that this is the model as it is today. And the only thing I control is every part of GG I need to answer to the best of my ability and as accurately as possible. And when we really think about which ones are affected by this, these are tasks that I would argue are not really the ones that end up with a lot of ANAs. And I'm curious, Sherry, by virtue of our chat box, if anybody else has any thoughts about that, because I'm not trying, again, I totally get the frustration. Having been on that TEP before they announced this to the rest of the industry, I was very frustrated about this crazy idea of math, but maybe I've had a little bit more time than the industry. And it kind of just hit me that We need to make sure we're not getting anxious about every item and trying to, then we're going to come up with solutions that say, why can't we just make them all dependent? Again, we don't want to round the corners on that compliance. If we're looking at that 150-foot distance question, it clearly states if they cannot complete, even with help, that distance of 150 feet, it directs us to use a non-attempted code as appropriate. So I don't know if you have thoughts, Sherry, if you just think I'm off base and we've had too many Zoom calls today and my brain's fried. Anybody has any thoughts they want to put in the chat box? I'm just curious.
Yeah, I welcome any of those questions or any comments that you have for the chat box, because that's how we learn, is by communicating in that kind of thing. I think we have everything covered as far as that first question. Is there anything else you wanted to add while people are trying to decide if they're going to jump in and add a comment?
Um, I don't think so. I just think when we start to see the impact of VBP, and it isn't even related to these GGs yet, because we know everything has a delay. The reality of VBP moving into true financial penalty, and folks are looking at that are getting a 4% hit, a 5% hit. I think that adds to this anxiety. But also keep in mind the current payment implications are not even about the GGs or the projected discharge. So we need to make sure we're appropriately focusing on data collection going forward, because those will actually have implications further down the road than this minute.
And I want folks to pay attention to the guidance that's being sent out, and particularly what the Alliance is doing. They're doing a yeoman's job of trying to keep us abreast of the changes that are occurring. With any new administration, you have some changes that occur in bunches. And so a lot of this stuff that came out about how the GG discharge levels were going to be calculated, that's kind of not young information, right, Cindy? So, I mean, the chances of us having some changes this year are pretty high, correct?
Well, but I think some of it is, in talking with folks, this is still related to the Impact Act.
Mm-hmm.
And that started a long time ago. And it begs the question, with this much time between when you said it started and where we are now, is this really what the Impact Act had envisioned? Is this really looking at meaningful quality data? Or has it become we're compliant with the Impact Act by kind of rigging together items we already have, and which ones are consistent across post-acute care that may not actually be as reflective of that care, especially in our setting, when you think about the exclusion of dressing and bathing and walking significant distances, those would be ones we'd want there. So I think taking some of that frustration into how can we be advocates for, I get what you're trying to do, but maybe there's a better way. I know that's what we at K&K try very hard to keep our involvement in when possible, the ear to the ground, and share with folks through our newsletter any opportunity to try to explain why we're not arguing with you about the idea. It just might be the execution is not really getting to meaningful data.
Right. And I think that, like I said, paying attention to that information is crucial, and having someone that's watching those advisories that are coming out as they're coming out is really crucial. Okay. Are we ready to move on?
Yep.
First, I wanted to mention, I added our image today because we're, 4 days out from Mother's Day. So I wanted to say happy Mother's Day to everybody who's with us, including my presenting partner right now. So thank you guys for being here, and just wanted to say thank you for being a part of the K&K tribe, if you will. And we're not here without you guys, so we can't say enough. And we hope you had a really, really happy and blessed Mother's Day. Okay, ready to question number 2?
Yep.
Okay, if an RN start of care and an OT evaluation were completed, but no further visits were made due to the patient not answering or returning calls for 2 weeks, should the discharge date be the date of the last visit, the OT evaluation, or the date we ceased follow-up attempts?
Those are those frustrating situations where we establish the need for care, we get things up and running, and then the patient essentially ghosts us basically on this description. In terms of the date of discharge, the official guidance makes reference to per agency policy. So we don't see in the official guidance that it says it has to be the date of the OT evaluation in this example, or it has to be the day we stop trying. So clearing the guidance, we don't have a you must, it just says agency policy. Personally, I would be leaning toward the date of the last attempt because technically you didn't discharge them at the OT evaluation. You didn't discharge them in that intervening period of time. You're ultimately coming to the decision to discharge them because you vetted everything you could think of and you just can't get a hold of them. So we're going to make the decision to discharge effective today. I also would make sure that there's sufficient documentation of those attempts to reach the patient, as well as physician notification of the issues at hand. Yeah, okay, I'm going to let them know I made the decision to discharge them today, but probably should be letting the physician know in that intermittent time of your attempts to get to them and you're not getting an answer. Or else the physician's just going to assume they have been getting care in that time between when they really weren't. So documentation becomes key, and look at what your agency policy is, if there is one, about what are we going to call the discharge date in these circumstances. Does that mean you have to have a policy? No, it references if you have one, you can refer to that. So if you don't have one, you may say, well, I don't really want to make something with every possible example in it. I would think that would be tedious. It isn't saying you're required to have one either, specific to the OASIS DC date.
Right, and we would be remiss if we didn't add a statement to this question, because it always comes out, what if we have a patient that received OT and then they were admitted by nursing because that's still the requirement, and then occupational therapy was the main need for the patient, and so OT went out and did their eval and nursing never did another visit. So Cindy, can you speak to that a little bit and how that can be risky?
Well, the challenge and why the documentation would need to be very clear that the visits were not made because we could not find the patient versus we just didn't make more visits. Because you're right, the single nursing visit is not considered a billable visit because it wasn't a skilling service. They were there to establish eligibility, but the service in question that was needed was OT. So you'd have some concerns about it being a single visit from both. The timing of those two visits, if they weren't on the same day, could call things into question. So I would really be careful about, we didn't choose this. This is just kind of how this worked out, in case that record was ever pulled in the future to say, well, we're not paying you for any of it because you just did a nurse admin and one OT visit. That wasn't by choice.
Exactly. So those kinds of things can be problematic, and we need to be aware of the rules that we're still playing under, and that could possibly be changed this year. We're about a month and a week or so from getting the proposed rule for home health, but we've seen some interesting things in the hospice proposed rule and the skilled nursing proposed rule that oftentimes will give us a harbinger to what's coming in home health. So if you haven't seen those rules, we've sent them out in our newsletter and wanted to make sure that you are aware of that and have the opportunity to review those and get ready for the proposed rule that it appears we're going to be able to comment on, Cindy, from what I've been seeing come out of CMS. So, get ready to comment and ask all your friends and colleagues to comment so that we can really have some input into what goes on. Okay, you ready for question number 3?
Yep.
Okay, and I wanted to remind folks that not only do we have the Club Oasis, which many of you are members of, but also we have education that we present on MedBridge, the MedBridge platform, which is an easily accessible virtual platform. And Cindy actually does a home visit and walks a patient through it and walks folks through it in her education. And Cindy, can you mention real quick all the cool things that you did with this product when Oasis E1 or Oasis E came out that was designed to help agencies?
I think my favorite part was the video of a home visit doing the assessment. So it wasn't saying, I am about to assess 1860, because that's not how real home care works. But it was doing an actual assessment, but videoing it and being able to use that as a learning assessment tool for folks that are participating. So watching a clip and then how would you answer? And then providing the rationale supporting the appropriate answer. Because I think it's one thing to verbally teach somebody, it's a secondary thing to use scenarios and things for knowledge assessment. but I think it's unique to say, let's watch this. What do you see and how would you score, particularly those functional items? That part I think is really interesting to help really apply the knowledge more than just reading a scenario.
Yeah, and MedBridge has upgraded some of their ways that you can pay for this platform. You can choose certain things. You can do it via the individual. You can do it via your agency. There's a number of ways you can do it. And they've tried to modernize it so that you can access what you need and not necessarily get bogged down, because MedBridge is a huge education company, and they've also started doing some things in digital health and other things. And so it's really kind of a new platform in a lot of ways. So if you have the opportunity, just scan that QR code with your phone. It'll take you directly to our individual page and all the things that we've done for MedBridge. But it is a great resource, especially in the days that we don't have as much to spend on education. It gives folks an excellent resource that's beyond just YouTube, right, Cindy?
Mhm.
They have a really cool list of clinical what's the word I'm looking for? Clinical comps of things like IVs, infusion, wound vacs, those kinds of things. And I know that a lot of our nurses and a lot of our therapists, if they have a question about a technique or a certain treatment, they'll go to YouTube to look. So what MedBridge has done is they've gathered experts in the field of home health and other healthcare settings, and they've provided a YouTube-like version for education. So definitely give it a shot. And if you've looked at it in the past, it's time to look at it again. Okay, question number 3. First we have an update. Nadine gave us a question. If we are going to DC due to the patient ghosting the agency, how should the OASIS items be addressed if it's been a longer time than 48 hours? Would this be an unknown or a dash?
Well, if you look at the April Q&As, and we did talk about them in our club meeting for Oasis in May, they actually addressed the non-visit discharge. They talked about, and that's really what it would be, whether it is they ghosted you or they refused that final visit. I refer you back to that because it does give very specific instructions about use of a dash versus patient unable to respond. And I know that one in particular is kind of like, but wait a minute, contextually, you've said unable to respond is I can't understand what they're trying to tell me, and no, they can't communicate effectively with me. They're saying that for questions that allow that in the non-visit discharge situation, that would be the recommended path to take for choosing those responses as well. So it ends up being a back it up to the last qualified discipline visit that did a actual visit to the home. That person gets taxed with completion. They can talk to people who have visited that patient within the last 5 days of the end to see if they can gather any information there. And then the rest of it, if we can't get it, defaults to things like dashes and patient unable to respond. But they did a very nice job in the April Q&A addressing it. So I'd refer the group back to that with respect to dealing with any sort of non-visit discharge.
Okay, so we knew this was going to come up today, this next question, and I'm going to give Annette Mays credit for this one. You little stinker, Annette. Anyway, it asks, can you give some guidance on Palmetto's most recent guidance on face-to-face relating to the community referrals?
Well, this is where, Sherry, I'm going to say I'm not a coder.
Okay, so the guidance that we've been given by Mary Carr with the Alliance is to hold steady. Keep doing your face-to-face exactly how you have been doing it with the guidance that's been around since before 2007. Don't change anything yet. It appears, and Cindy, if I'm talking out of turn, please tell me, it appears that Palmetto may have posted this prematurely, and they have since erased it from their communications. So I would really heavily advise everyone to stay tuned, hold steady. I know it's exciting. I'm excited about it too. Some of the changes may actually turn in the provider's direction. And boy, howdy, are we due a win in this. Cindy, did you have anything to add?
Well, just, I don't want to cause everybody to kind of run out and grab the website and try to figure all this out. There was a directive changing some of the requirements around face-to-face from CMS to the max. And the reason the advice is to hold steady for now is that the max are not consistently alerting agencies to that change or how they're doing it. It's on one website, it's not on other MAC's website. And the concern is if it's a website statement, but not an actual change to the rule itself, are we really safe going guns blazing into this new arena? So it is an exciting possibility. There are some thoughts that this may actually be some insight into what could be in our proposed rule in July. For those of you who are like, I have no idea what this woman's talking about, it's okay. Nothing, we don't have a consistent enough change to do something, but those of you who, keep an eye on your Mac website, or someone said, oh my gosh, did you see what Palmetto put out there? Does this mean what I think it means? We're just backing up the Alliance's position of caution. And any question you have about that, I would not take it to any peer, including us. I would take it directly to the Mac and ask for clarification about what this really means. Because if the information came CMS to them, I'm not about to jump in the middle and try to decipher it, because it's not quite to the level of a regulatory change that everyone's aware of. So I'm not saying ignore it, stick your fingers in your ears, but if you're a Palmetto State, you've seen it and you have questions, I would direct it right back to the Mac.
100%. And that literally is still up on the Palmetto's website, apparently, Cindy, on this note, because the other fiscal intermediaries have not posted this, nor have they posted a guidance update. I almost wouldn't listen to any experts in the field. And again, Cindy iterated it, including us, until we get further guidance. And Mary Carr spends her entire day looking at home health regulations and trying to help us. And that's guidance kind of straight from her. So we're in a holding pattern just like you guys are. But boy, wouldn't it be exciting again if we could get a win in this, right, Cindy?
Well, the challenge around face-to-face briefly, despite all the moving parts, is the continued disconnect between what's written in statute and sometimes the directions we're getting given. And I think that's always left some sort of question about what really is the rule, what really is okay in some of these situations. And so some of that hesitancy is a statement versus a rules change. I know many have been advocating to CMS. So what really needs to happen is you need to change the wording around your official rules and not just other statements through the MAC. Because if your rule still reads different, are we still at risk of being told you didn't follow the rule?
Exactly. I mean, that's something that you don't want to get involved with, particularly if you have the opportunity to just pause a little bit and let it get back to where it should be, so that we know exactly what's going on. So,
but Sherry, to Annette's point, trust me, Annette, I heard about this before Sherry, and I thought, oh my gosh, this is newsletter. This is going to be, and then I'm thinking, no, and I was listening to the folks talk about it and the hesitancy, because I was right there with you, like, man, this is good. But if there's a chance that it's not quite fleshed out yet, I rather wait a bit and then blast the heck out of it when it's like confirmed real across the board, and then we can do our little celebration, as opposed to start blasting it and then, like Sherry said, has happened with other Palmetto things in the past, then it disappears off the website, and then we've told people stuff that may get them into trouble.
Exactly. So that's something that at K&K you can count on. If it is a misguided guidance, if you will, we're not going to try and fit that round peg into a square hole. We're going to wait until we know for sure, and then we'll send that guidance out to our subscribers. Okay, Cindy, you ready to move on to question number 3?
Yep.
And as a reminder, if you have any adjustments or anything you want to add, please use the chat box. We're monitoring that in real time, and we'll hopefully get all the information up we can. But we had some great submitted questions this time, so we want to make sure we get to as many of those as we can as well. Okay, this question: when having to DC and readmit because of a payer change, oh, that never happens.
Every January.
Every January. We select DC with formal assistance since we'll be picking them right back up. Are we still negatively penalized on outcomes in this situation, or are they excluded from STARS and VPP?
Well, first, you're doing the right thing following the OASIS guidance that it is choosing with formal assistance. It specifically states in the guidance that is what you do when you're making this change, basically, of a payer change. With respect to outcomes, if you think about this, that record is not able to be flagged in any way that that was done for a payer change. I mean, if you laid them out side by side, you could see the change in the payer in that response item, but those responses of continued with formal assistance could also be marked because they went to another home health agency and not yours. So the issue of the outcomes, I think, in many cases, at least in my experience, and fire away in the chat box if you see something different, more often than not, that payer change is from a non-Medicare to a Medicare payer. And more often than not, the previous payer was not one recognized in there in terms of being part of VBP or Care Compare or STARS. So although you were collecting the data on additional payers, CMS was not utilizing that data for any sort of outcome measure or any of the rest. So actually converting them to Medicare with that new start of care would be starting a new episode from a quality perspective in with a payer that is part of those models. Now, the flip side, because many people bring this up to me every January, is we've had this person before. They really were bad when we started. They have gotten better over our care. I have to do this now as a payer change. My new start of care is showing them better than the old start of care. What does that do to my quality episode? I think that's part of the frustration of having to do this at all in January, in particular, because now it's like, yeah, it's a new quality episode. That's great, but I'm starting even higher, and I kind of lost what we gained in the previous one under the other payer. So there are implications of this. What's going to be very interesting to see down the road with the move to all payer data collection, would that impact this to the positive to say, well, it doesn't matter what the payer is, or will that potentially change in future rulemaking, whether or not I have to do a payer change every time they do that? And some of that remains to be seen. I think also what's interesting in the April Q&As is for them to basically list out all the things they are not going to do with the data for all these other payers. And I know from my perspective, it's like, maybe you should have worded that differently. Like, we're not doing this now, but we are considering it later. Because if you're telling me I have to do something that's mandatory, and then you lay out this laundry list of it won't affect VBP, it's not part of STARS, it's not Care Compare, it's not blah, 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 then it leaves me going, Sherry, why am I doing it? Like, why is it mandatory? And then you tell me you're not using the data for anything. All I think it would have taken is not at this point, or, this is baseline for something down the road in the future. Because I know for me, you read it and you go, oh, so you want it, you're making me give it to you. And then you tell me you're not doing anything with it that affects these key issues. So I think there's more to see what happens around that payer transition once we go to all payer submission, and what that might be from an after effect standpoint.
Exactly. And I think that, being conservative in those situations as well is always the best thing to do. And if you suspect that there's going to be a change coming up, you can't anticipate that. You have to wait till the date of the actual change, Cindy. And I just kind of wanted to guide folks on that. And that's the unfortunate part, because that means that, the first week of January can be HE double hockey sticks. That's an old way we used to say the dirty word. Anyway.
Well, but if I can add something to that, Sherry, because we see this on our outsourced coding and OASIS side, is agencies that don't find out about it till way later.
Mm-hmm.
And I think it's just a quick sidebar reminder that if you know that this is, enrollment period, and this may be when they could make a change, proactively, talking to patients about this so it's coming. As opposed to when we get contacted, we found out, at the end of the episode, we found out a month later, and we have to go back and undo. If we know it's coming, it's better. And I think we just need to start thinking about how are we canvassing our patients so we know, so that the oopsie, they forgot to tell me is more of a rare occurrence than any sort of, regularity or frequency.
Exactly. Okay, so as we go to the next question, I want to change to this slide. No, Not the next one. Okay, this is an Oasis question, Cindy, and a reminder that it's not too late to join Club Oasis.
Right.
Everything that we've done so far, we have recordings of and communications through a bunch of professionals just like you that are helping each other out. So definitely consider coming into Club Oasis. Okay, Cindy, you ready?
Yep.
Okay. For A1250, how should the item be answered in a scenario, which is transportation? How should the item be answered in a scenario where a patient would have access to transportation but can't get out of the house to get to it due to functional limitations, i.e., not able to descend the stairs, and therefore has not left the house in 2 years?
Ugh, these are those no, those are those painful Oasis questions, Sherry, where we have to remind ourselves, okay, this is discipline neutral data collection. Many of you are like, oh my gosh, how many times can the woman use that phrase? Because it's foundational to trying to make peace with dealing with issues like this. So we understand that these are not clinical questions. More often than not, they are not super detailed questions. They rarely get into the why someone can't dress, can't bathe, can't take their medication. They're simply looking at standardized bits of information, and I would argue some of them are incomplete thoughts. That being said, when they set up parameters for some questions, they have to set boundaries somewhere. And though powers that be that write these questions sometimes set boundaries that when we look at real life are either frustrating, ridiculous, or both. In terms of the ability to access the transportation is not what 1250 is about. Now, have your moment, if you haven't had it already, of saying this is stupid because you're telling me I'm going to report that they do have access to transportation, even though they haven't left the house in 2 years for a very valid reason because they don't have the mobility to get down the stairs and get to it. The question is about the access. Functional impairments that affect its use are not within this question. Now, this is where Q&As, if you have a burning conviction on this and want to express that through the Q&A submission process, you can. But the issue is, I'm looking objectively, discipline neutral data collection, at the access they have to transportation for medical appointments and those kinds of things, and not whether or not they can get down the stairs to get to them. And I know that that just clinically feels really dumb and frustrating because this is a significant problem for the patient. And I would absolutely be documenting that although they have it accessible, they physically cannot get to it. And how has that affected their ability for medical appointments? What is involved, because it talks about groceries and different things like that. What modifications have they made? Because we may look at that and say, well, that's not fair. But if we're able to document that they get, visiting physicians come for appointments and they've arranged for grocery pickup and all those other things, then although we may not like the data here, the patient has developed a plan that actually works for them safely. Or if we find that they have some holes in that, that might be an opportunity to bring in a social worker referral to say, how can we help alleviate some of this given your mobility issue?
Okay.
But quick Oasis sidebar, Sherry, I would absolutely expect that other parts of the Oasis related to their mobility, function, and use of stairs should back this up.
Yes.
Because there's times I see that description in a narrative and that frustration around 1250, and then I get to the GGs and it's like, what did you put here for stairs? What did you put here for the other? Because this doesn't really line up with that. So you want to make sure those other mobility responses fit with it so that it paints a picture of, yeah, it's great he has access to a car. Problem is he can't use the stairs.
Right, exactly. And I think it's really important that we have that expert information as that guidance comes out. And I will again just encourage you to look at the April Q&As and look at the ones that are going to come out in July and stay abreast of any of those changes or any of these questions that may come up. And some of those of you that have been into multiple of our Q&As, you remember that there's questions we can't answer, and we've actually encouraged folks to submit them to the Q&As on a quarterly basis. And one of those questions, it took almost how long to get answered, Cindy? The one about the functional item?
Oh my word. That took multiple cycles and you know, being transparent, it took me giving the question to someone else and having them submit it before we finally got an answer. I don't
And
know. I must be on some list. Maybe there's other people listening to this, Sherry, and I end up on some naughty list that they didn't want to answer my question, but I'll keep trying.
And I want to apologize again to everyone that we had these technical issues this morning or today, and we got on a little bit later. So we're going to be cognizant of the time and abbreviate some of the question answers. And that way, those of you that are scheduled and have to get out of here at 2 o'clock, we want to be appropriate with your time. But we will stay on for any additional questions that may come in through the chat until we don't have to stay on anymore. So Cindy and I are going to be flexible with that so that we can meet your needs. Okay, Cindy, I put a big can of worms into the Q&As today,
Yeah.
and I don't even think you know about it. So here we go.
Uh-oh.
Let's talk artificial intelligence. Okay, has anybody on this call heard anything about AI and what's going on in home health and all these options that are now available for you? I know that Cindy and I have, and we've had the opportunity to review 7 platforms now, Cindy.
Something like that.
Yeah, and we've been walked through by the developers and given the opportunity to give feedback on those things. And I just wanted to let you guys know that you need to do a survey of your agency, whether you've purchased AI, whether you've considered purchasing AI, whether you've had a demonstration done. But you need to probably do a survey of your clinicians because I guarantee they are using some form of AI currently. It could be as simple as talk to text. It could be as simple as using ChatGPT to alter some of their notes. And I think that it's really important that you know where you are right now with AI prior to deciding to make a big wholesale change with AI. Cindy, did you have anything to add to that part of what I wanted to mention today?
I just think that the idea that we're just going to bury our heads in the sand and say AI is just never going to be in home health, is unrealistic. I do think, though, that it reminds me a little bit of when we went. I'm so old, Sherry. I remember when we went from paper to computers, and everybody was telling us that the computer was going to make you faster, that it was going to, be able to do more visits per day. It was going to take all of these burdens off of the clinician. And ultimately, that's not really what happened. It created a lot of efficiencies. It made things legible. It could give me more access to other information. It could give me access to Oasis guidance at my fingertips. But did we ever see it magically made clinicians able to do 8 visits a day? No. And this reminds me of that with some of the, you can do an Oasis in 15 minutes. It does all your documentation for you. I think the ones that I feel less anxious about are the ones that don't forget that the 2 eyes of the clinician, the 2 eyes in the brain have to still be in this. That AI could be a huge tool for scrubbing referral documents and giving information. It could be good for, reminding me certain elements of OASIS questions. But I still have to be in the driver's seat as the clinician, as the agency. And particularly around OASIS, we all know that's my passion area. I get concerned about a solution that further takes the process out of the hands of the clinician. Because we already know, those of you who do review, sometimes the correction process is that's a very nice clinician. They never argue about my corrections. But if I have to make the same correction one more time, I may become murderous. So you're passively agreeing, but now if it's AI going to answer for you, how diligent are you going to be to look at that answer? Or are you going to see this as expediting a document you don't want to fill out anyway and just agreeing? So I'm excited about Elements. I think it's good you included it, Sherry, just because it needs to be on the radar. But I think any of it, even if it's talk to text, you and I see so many of that filled with typos, sidebar comments where they're clearly yelling at their dog, things that make absolutely no sense are in there. If they're not rereading that dictation, what happens when it's something that's promoted as, look how much easier this makes it for you? So
Exactly.
it's just thinking about that and always reiterating that the data collector has that responsibility. The documenter has the responsibility to look at it. Yeah, it's like dictation of old on steroids, but you still had to go back and look at it and made sure it understood what you said, that it means what you say, and wasn't just I signed it and woohoo, I'm done because I hate to document anyway.
And Cindy and I are big proponents of this advancement in technology. And in fact, in our other what we do in outsourcing, we could really increase the productivity of our reviewers if we use the AI that can read the past medical history and the history and referral documents that come from a hospital. Those of you that know what I'm talking about, sometimes they can be 100 to 200 pages of information on really complicated cases, and having something that could accurately read that document and show me the highlights, that is a powerful tool. However, it is beyond me, and I've never had any of the AI folks tell me that they can read the scribble that oftentimes we have to interpret. We have to use the rest of the chart to interpret what they're saying, or if it will highlight those one-time mentioned diagnoses in a chart. A patient recently we had that had over 70 pages of documentation, literally had one line that said that they were currently in a outbreak of shingles. And because they found it on the admission, it became a priority because the patient was having issues with pain. They were having issues with getting their viral load under, and they had to start a new medication for shingles. But it is possible that would be missed by the human eye, and it's very possible it would not be highlighted in the AI perspective. So step cautiously. Cindy and I are a little bit hesitant to believe that clinicians will be great editors if they're not great documenters. And just be aware that anytime you go into a new era, if you will, of tech, that you have to go in with cautious optimism, and you have to educate and review, because ultimately I don't see a scenario, Cindy, where we could be brought to task on an audit and we could say, well, AI told me to do it, so it had to be right.
Right.
And
And Sherry, just for some people who may say, but that really wasn't a question, Sherry. That was a platform for us to talk about. It is a combination of questions. Sherry and I get asked about this fairly regularly about the role of AI, what we think about AI, and as she said, looking at demos. So we wanted to, Sherry included it, but I think it really is kind of a summary of the questions and our concerns. Again, cautious optimism is, I think, the way to go, but always with an eye toward if it seems to be over promising, a little bit of skepticism until it can prove it is not a bad thing.
absolutely. And the thing about AI, if it does speed up some of these things, the errors will be made fast. They will not be made slow. And that means that more errors could be made in a smaller amount of time, which is always scary to me. So just be cautiously optimistic, do some reading, keep yourselves on that, edge of technology so that you can improve your efficiencies and improve your profit. And as always, we will be a resource, and we're out bird dogging the regulations around this. We're bird dogging the quality, and we want to make sure that we give that to our customers. And I hope that those of you that aren't from the South understand what I mean by bird dogging. We're actually trying to dig up information that will be helpful for our subscribers and the people around us. So
Can I add one more thought, Sherry? Since this is not a super formal platform, but an important one, I also would caution against exclusively getting educated about AI by a vendor of the product. I think that, no offense to vendors,
we are
but they
one.
have, yes, but they have skin in the game to sell that to you. I would be looking for other agencies that have used it. How much has this been done in home health? Other perspectives than simply just the person trying to sell it to you. So when I look at some of the events around AI and home health and every speaker is a vendor, I get a little bit nervous about how objective is some of this in the reality of what it's going to take to do this in home health. So I'm not suggesting anybody's, lying or anything like that. I just think we need to think about where am I getting this information from before I jump in with both feet.
100%. I like the way you put that. So as people are leaving, we have one final question. Sit to stand, GG0170D versus bed to chair, GG0170E. If using a Hoyer lift, for the GG0170D, would they be scored a 9 or an 8, an 09 or 88, depending on whether they are at their baseline or not, since they do not stand? And for GG0170E, would they be dependent since they are getting from the bed to the chair with a device? We are concerned about DFS and expected improvement if we use 88 and dependent. Can you help us understand this scenario?
Okay, this is a great question that tees up this exact information is in the official guidance manual. It does address that sit to stand with a Hoyer lift situation. If they are completely unable to complete that task, they do not come to standing, even if you try two people, then you are looking at a non-attempted code, as is written in the question, between an 8 or a 9. We know that moving from the bed to a chair, yeah, we could argue that sit to stand is part of it, but in a Hoyer situation, that is a separate issue to look at. And if it looks at the amount of assistance that this patient needs, you wouldn't automatically assume a Hoyer is dependent. Is the patient performing some of that task in terms of positioning in the sling, getting in the right spot, holding on as they go over? Then you'd be dealing with some of those response options possibly about greater than 50% or lower than 50%. I wouldn't say a Hoyer is an automatic dependent. But then again, we have that connection too. But what does that do to my measure? Because we're using, 8/8, and a patient that is that compromised, I would expect to see additional compromised things gathered throughout the GGs. And that again is taken into consideration when looking at the subset of what they look at for the discharge functional score. But one more point I want to make, because of that inclusion of, is that response dependent? I think the response dependent, and many of you have heard me rant about OASIS many times before and know full well that I am never, ever going to be the person who tells you sneaky ways to upcode or do this and make them all look artificially half dead so that your scores look better. But I'm becoming very convinced in working with agencies and talking to clinicians that we're not necessarily using the responsive dependent appropriately. I think, and to its fullest potential, given the guidance. Because I think when we're looking at dependent, we think about Hoyer lifts. We think about people that cannot participate in any meaningful way. I think when we encounter a patient that is that impaired, we choose the responsive dependent, and that is how it's even written for the GG items. But much like the battle we've had for decades about 1850 and that placement of the word or, so if you need someone or something, the minute you need someone and, then you have to drop a response lower. The or independent talks about the need for two people. And if you look at the decision tree embedded in the guidance manual for response options in GG, independent is clear what it is. All the ones between that, 5, 4, 3, and 2, all clearly state one helper. The minute there's two, we're dependent. So I've been writing some scenarios lately about the patient needs, less than 50% assistance from their spouse. The clinician is providing verbal cues about walker placement and positioning. That's dependent. And I'm sorry, regardless of discipline, it is not clinically. You're like, wait a minute, less than 50% and the other one talked? Yeah, those are examples within the guidance manual about if two people are required to do this safely, you're dependent. And so I think about how clinicians have struggled for quite some time to pay attention to their verbal cues and their supervision. They say things and suggest things. But if one person, that family member, is physically assisting and I'm providing necessary cues, that is two people and that's dependent. So I struggle with that, Sherry, because we fought on so hard about no upcoding, but the more I'm digging into this and using scenarios and working with agencies, I think we might be underutilizing dependent based on how they defined it, not how we did. So decision tree, look at the examples around that. I would use those because you're going to go to, especially some therapists, and say that's dependent, and they're going to want to fight you. They're like, that is absolutely. Don't say, well, Cindy Kraft said, well, then they're going to try to come fight me. Give them the guidance right out of there, because I think we've missed for years potentially an opportunity to follow rules we don't necessarily agree with, but huge more room to be able to show improvement. If that's how they want to define dependent, I didn't. That's what you said. And I can show you it took two people. I've got all kinds of room to move up.
Exactly.
So I just think it's one of those, and Sherry, again, I'm repeating myself. I struggle with it because I'm a PT, and that is not how you define dependent. That's the two-man drag. That is two people pulling you out. That's not one person touching and one person talking.
Well, my
But
favorite, the old Max Assist of 2, which means that Max Assist of 2 is basically ambu drag.
yes, the
Yeah.
skilled nursing drag thing. But so I think I just wanted to make sure that we had that as part of this Q&A, because I don't think I'm the only one seeing this or needing to revisit this, but it could be a teachable moment. Now, quick sidebar. Does that mean we could look at this and we now see a change, appropriate change in our data to an increased use of dependent? And then somebody may go, hey, wait a minute, are you trying to make them look half dead? If it's two people, make sure the clinician's documenting both people and what they're doing, because then it's no doubt that they chose the response based on the instructions, not some sort of gaming effect. So if it's, somebody had hands on and I provided verbal cues for this is two people, then no one can say you did something sneaky to try to make your outcome potential better.
Exactly. And I put up this slide about our outsourcing, and I'm not doing it so that we can market you to death about outsourcing, but a big fix to this is to have professional folks looking at your documentation. And we provide that services. So if you scan this, it'll take you to our Contact Us Outsourcing page. You can simply set up a call and we'll discuss what's going on in your agency. Even if you currently have an outsourced company, talk to us about what you should expect from that outsourced company. We'll offer 30 minutes of free advice on that stuff. And also we offer that services. I mean, that's a no-brainer. Just reach out and chat with us independently and let us know some of the things and some of the challenges you have in your agency and whether or not we can help, or we can send you armed with some information that you can go back to your current provider and improve their service. Cindy, did you have anything else to say about that?
No, I think you covered that well. And I know we went a little bit over because we had our technical issues at the beginning. So we appreciate those who hung on. And I'm glad that we have a recorded version for those who had to step away. They can catch that last little bit. And please continue to submit questions in between these.
Yes.
If it's an urgent issue, label it urgent. But if you're thinking, hey, that would be a good one for the next Q&A, just label it that. We love the feedback, and it really helps us think about things potentially a little bit differently as we prepare for the next one coming up.
All right, and now I put up the last page. It gives you our contact information, so you can also email us directly with any questions. Like if you don't want to use the link, if you don't want to go to our website, just pop our email in and send us any questions that you have. And many times, like Cindy said, we'll answer them right away, and we'll include them on the next Q&A if it's something that we feel like everyone else should know. And I believe that the captions may be blocking the date of our next session, but it is in July. It's July 17th, and it'll be from 1 to 2 p.m. And hopefully we will not have these issues going forward. So thank you guys so much for your attention and your patience with us today. And we strive to get better and better with these Q&As. They've become extremely popular, and we want to make sure that we're providing a good service. So if you have any recommendations about how we could set up our Q&A or things that we could do to get better, please let us know. We are at the mercy of how our information is received, and we want to do that the best that we can. So I just want to thank you again for subscribing to K&K, and I want to give you the opportunity to help us improve. So thank you so much. Cindy, any final thoughts?
No, I wish everyone a great rest of their day.
Thank you so much, and I'll be sending the recording as soon as it's available. Have a great day and be safe out there.